All right, we'll kick off. Hello and welcome to today's webinar on empowering circulation, the ABPI's impact on arterial and venous health. Thank you for taking the time to be here today. My name is Matt and I'm the Senior Marketing Specialist at SSS Australia. We would like to thank Lymphoedema Therapy Training and Education for today's webinar. Our speaker today is Jacqui Beutel, founder of Lymphoedema Therapy Training and Education. Jacqui is a nationally and internationally recognised lymphedema expert with a passion for improving patient outcomes. Jacqui is a registered nurse and decongestive lymphatic therapist with extensive experience and over 20 years career experience in the treatment, training and education related to lymphedema. So before we get started, this session will be recorded for future training purposes. Can you please make sure that your microphone and camera are turned off for the duration of the webinar? To submit questions, please click on the chat box at the top of your screen. These will be monitored during the webinar and relevant questions will be answered during the Q&A session at the end. Keep an eye on the chat screen as well. We will post a link to the feedback form where you can let us know how the learning session went and if you would like to receive an attendance certificate. A copy of the slideshow will be forwarded to you later this week with supporting information. We will also have some discounted pricing available on the ABPI monitor, stands and related equipment in that email. We respectfully acknowledge the traditional owners of the land in which we meet and pay our respect to elders past and present. Welcome to everyone who's just joined. Please use the chat box at the bottom of the screen to ask any questions and send comments to our speaker, and we will get to as many as we can. I'll now hand over to Jacqui.
Thank you, Matt. I'll just share my screen. Alrighty. Can we all see my screen there?
Yep.
Yep. Alrighty. Okay, so good afternoon and welcome to this workshop on empowering circulation, the ABPI's impact on arterial and venous health. So ABPI stands for Ankle Brachial Pressure Index. It's also referred to as ABI, which is the Ankle Brachial Index, and we can also perform a TBI, which is our Toe Brachial Index. My name is Jacqui Beutel. I started out as a remedial massage therapist and gained qualifications in oncology, massage and decongestive lymphatic therapy. I'm a fairly newly graduated registered nurse, juggling lots of roles as educator and a lymphedema therapist, as well as an RN. And I mostly treat lymphedema patients, so anything to do with the lymphatic system. I have a signature course, which is decongestive lymphatic therapy and practitioner course. And then I have an informational membership site that I've launched for health professionals. So as Matt mentioned just before, if you'd like to submit any questions through the chat box, we'll get through as many as we can, and any that aren't answered, we'll send out through an email to everybody at the end of the session. So today our focus is going to be on the lower limb. We need to work within our scope of practice and follow the guidelines and parameters as set out by your facility. So this is a really big topic and I can't cover everything in just the 45 minutes, although I'm going to try to. So you need to do your due diligence and get some extra training or come to one of my courses. I'm going to try to cover today describing the difference, or just a brief description between venous and arterial disease, recognise the role of the ABPI in identifying PAD or peripheral artery disease, look at some of the typical assessment findings, determine patient suitability for lower limb compression and evaluate treatment options, and looking at our referral process and collaboration with other healthcare professionals. So what do we need to do when a patient presents with swelling or oedema or wounds or changes to their lower limbs? We need to provide a safe and effective treatment plan. And to do this, we need to answer the 5 W's and the 1 H. So that's who, what, why, where, when, and how. And to take a health history, perform an examination, both visual and palpatory, and then look at some relevant testing. Once we've got all the information, together with our expert team or in our sole practices on our own, we can start to provide a person-centred care. So we all need a why to do what we do, and this is my why: education on the safe and effective use of compression. So this photo is of my dad's leg taken back in June 2014. My dad was a chain smoker and he drank. He was 6'2" and quite lean. My dad saw many doctors very regularly as he was prone to skin cancers and was often having an excision. He initially presented to the doctors with a rash on his leg, a really small rash that kept getting worse and eventually caused oedema in his ankle. He saw lots of different doctors for this for over 3 years and each time was just given a fungal cream, a diuretic, and was told, you need to live with it. I lived in Brisbane and even on weekend visits, I never saw Dad's legs. No one saw my father's legs. He always wore jeans. And then this one day I had to come to Gympie to take him for an excision because Mum couldn't drive. And he showed me his leg. I was absolutely horrified that I had never paid any attention to his whining about his leg and that the stories he told me about how he had been treated at various medical practices. So at the excision, I asked the GP if there was any reason why I couldn't put my dad in 30 to 40 millimetres of mercury of below knee compression. The doctor scoffed at me and told me it wouldn't do any good and that it was too high a compression for a man of his age. So we agreed on 20 to 30 millimetres of mercury. The doctor hardly glanced at the wound and a nurse had never looked at it and Dad had never had an ABPI, nor were his pedal pulses ever checked. For better compliance, I made Dad buy his own stockings, Jobst for men, 20 to 30 millimetres of mercury. I explained to him about compression and that he would need to cut his nails and be very careful. So the first time he pulled his stockings on, he put a hole in them and then that lost compression. So he used to cover his leg with sorbeline cream, put on his hold compression stocking, put his work socks on over the top, head off to do his chores around the yard. And at the end of the day, he peeled his socks off, hung them over a chair, and he repeated the next day. He washed his socks a couple of times a week. I saw Dad again 7 weeks after he started wearing compression. And this was the results. So the top picture is Dad in June 2014. The bottom picture is 7.5 weeks later in August where he's got a healed leg, but there's still some inflammation there. And then at the 4-month mark, his leg was almost healed. So this was just a Band-Aid for Dad. He needed to see a vascular surgeon, but Dad didn't have the capacity to actually get to Brisbane to see a surgeon, wasn't going to be compliant and didn't have any money for any follow-up treatment. So the stockings worked well for him. So this, although it was just a Band-Aid for his venous problems, his quality of life was dramatically improved and he didn't have to deal with the crusty weeping sores or that venous eczema and his oedematous ankle. So Dad continued to wear his stockings as it stopped his legs from aching until he died about 4 years ago. So how did all of this happen? As a massage therapist, back when I was a massage therapist, we were told that if you haven't made a difference within 3 visits, you're not the person for that patient, you need to refer them on. But for Dad, this went on for 3 years, and although he'd seen many different doctors, no one had ever done any proper testing on him or even suggested that he might need a vascular surgeon. No one felt his pedal pulses and no one definitely offered him an ABPI, and there was never any nursing intervention. And he was at the doctors very often for skin cancers and had every opportunity to have this looked at. The condition was blamed on age and poor lifestyle, like he was a smoker and a drinker. Had he had a health history properly taken and a visual and palpatory examination done, they would have seen that Dad was almost hairless on his lower legs. He had vascular changes, he had poor toenail health, his legs were cool, and he was a tall man. That should have alerted at least one of the GPs that something wasn't quite right. For hair to grow and wounds to heal, it needs oxygen, and oxygen is carried in blood. So if no blood is getting to the lower extremity, then we're going to have a problem. That, in my mind, requires the intervention of a specialist in the field. Dad didn't just wake up one morning with lower limb the way it was. It took time, and he did do a lot of follow-up to find that out. So I'm going to talk briefly about venous versus arterial disease and the tests that we can do to help identify suitability for treatment or a referral to a vascular surgeon. Had my dad been offered an ABPI and had a proper examination and treatment, his treatment may have been significantly different, not to mention his quality of life. I did put Dad in compression stockings, even though he had a combination of venous and peripheral artery disease. So a lot of people are too scared to put patients in compression when they've got PAD, but it just requires a little bit extra effort and a little bit more monitoring and a different style of garment. So there are many types of ABPI devices on the market at the moment, and I'm just going to let you know what sets the SmartDop apart from the rest for me. So it can be hard to choose one brand over another, particularly as it's a large financial outlay, and sometimes we don't really know what we need. Should we save money and get a 3-cuff, or do we need to have a device that's portable? Should we get one with toe cuffs? Do we need a vascular Doppler? What sort of training do I need, and what is offered out there? So the reason I have the Smart Dop is the equipment has 6 cuffs. It has 2 arm cuffs, 2 ankle cuffs and 2 toe cuffs. And so this means that I can do a toe brachial index on patients that are contraindicated for an ankle. And we're going to talk a little bit more about that as we get into the talk today. But also the service from SSS Australia has been exceptional. They've always answered the phone every time I've had a query. So they have 2 devices. I actually have the XT6, but I'm going to talk a little bit about both of them. The XT4 is a device that comes with 4 cuffs, so 2 arm cuffs and 2 ankle cuffs. And it has the software, and it's very usable and suitable for anybody. But the XT6 comes with, it's a bells and whistles model. It comes with the arm, ankles and toe cuffs. It has a temperature probe and a vascular probe. I believe that everyone needs to have the toe cuffs because there's a lot of demographic that can't have the ankle cuff, and we'll talk a bit more soon. So just a bit about these 2. It's a 4-cuff system. It inflates the arm cuffs first and then the leg cuffs, which prevents cardiac overload. It also measures those toe pressures, and that's really useful for anyone that has legs with really large wounds, that have a lot of pain, have edema or a large limb circumference, or anyone with arterial calcification, which is pretty much going to be our diabetic patients. It also does an ankle pulse waveform, which is important when the ankle brachial index results are inconclusive. So it assists with the diagnosis. And it also comes with the Doppler for pedal pulses, the blood pressure section. It has an optional stand that you can get, and it weighs about 3 kilos. So for those of you that are wondering what a pulse volume waveform looks like, this is a picture of it here, and it assists when it is difficult to get a diagnosis from the ankle versus the brachial index. So I'm not trained in interpreting these waveforms, but we've all seen Grey's Anatomy, and we know that the bottom right corner is definitely what we don't want to see. But fortunately, this does not mean the person's about to flatline. It's just that it's showing severe peripheral artery disease. Regarding a 3-cuff system, I just will tell you a little bit about what they are. So international guidelines recommend that measuring systolic blood pressure on both arms with the higher value most clearly reflecting the central aortic pressure is the one which we need to use. That's why the highest value is used to calculate the ABPI. So what you do with a 3-cuff system is you'd have to take the blood pressure in both arms, and then you would take the highest systolic pressure, and that arm you'd place a cuff on that arm, then you'd place the cuffs on the ankles, and then you'd do the inflation. So that means effectively that you're putting a blood pressure cuff on one arm at least twice, and then if you had any other problems like a poor reading or a kink line, or the patient talked or moved around and we had to do it again, you may be placing that cuff on an arm 3 times. So that can cause, that overinflation can cause venous congestion, let alone the pain. Some of these 3-cuff systems have an add-on of the toe pressure measures, and they're usually a little bit lighter, and some you can add on a 12-lead ECG spirometry. I think they're messy. You can add on extra things, but then you've got all your eggs in one basket. Regarding the importance of measuring the both arm, I just tried to do a visual here to show you. So if I just didn't know that I had to do the blood pressure in both arms and I placed it on the patient's right arm, it's measuring the systolics 110 and the ankle pressures are 105. Ankle brachial pressure index is ankle over brachial. So the ankle is 105, the brachial is 110. That would give me a reading of 96. But I don't know what the left arm is. So I would inadvertently place this person in maybe grade class 2 or class 3 compression, not knowing that I had not taken a correct reading. If I did the blood pressure in both arms, I might find that the blood pressure in the left systolic was 140, and that would give me a reading of 0.75. So that's not compressible. So it's really important that you make sure you've got your right systolic pressures, which is why we'd get a 4-cuff, because the automated system takes that out of our hands. So you may well be asking yourself why having a client's ABPI result is important. And I guess the answer is relative to the treatment and your scope of practice. But the British Lymphology Society's position paper for informing decision-making prior to the application of any compression therapy in 2018 found that the arterial vascular status of the legs of all patients with lower limb edema or lymphedema should be assessed. And this was backed up by the lymphedema framework, stating that the presence of peripheral vascular disease may contraindicate compression therapy or necessitate a reduction in the level of the therapy used. So to be able to put someone in compression, you have to be able to have a baseline, and to get a baseline, you need to do an ABPI. So there's many papers that confirm that compression therapy should be 30 to 40 millimeters of mercury as the gold standard treatment for venous disease. But how do you know if someone presenting with a wound or lymphedema has an underlying venous arterial disease? So is it even something that you would have considered checking for? But performing an ABPI will help you answer this question. Chronic venous disease is described as a chronic condition related to or caused by veins that have become diseased or abnormal, and it affects the area between the ankle and the mid-calf called the gaiter area. It's the inability or restriction of blood flow to return to the heart, and affects 2 in 1,000 Australians. Some of these will develop an active ulcer, and out of those ones that develop an active ulcer, 1 in 3 will have more than 10 episodes of ulceration. And that gold standard treatment, once someone has a venous leg ulcer, is wound management and compression therapy. The stats are a little bit old. It's hard to get up-to-date statistics on vascular disease, but the most common type of chronic wound managed in the Australian primary care setting, as our GP practices, is venous leg ulcers, which accounts for about 70% of all chronic wounds. They are underdiagnosed and undertreated, and costing the Australian health care system millions of dollars. And in fact, almost 10 years ago, it was 3 billion, so it's probably quite substantial now. Treatment regimes for venous leg ulcers is dressing 76%, pharmacology or antibiotics about 25%, a woeful 2% get the gold standard medical compression, and only 5% are actually referred on to somebody like a vascular surgeon. So education for both staff and patients is the key. So some staff lack awareness of the guidelines and lack an understanding on the benefits of medical grade correctly applied compression. How many patients have you seen or even applied yourself and then been mortified afterwards, and you've seen what's happened, the way the tubing grip's applied? So in this diagram here, you can see that there's a wound dressing, and you can see that the tubing grip's been placed over it and has caused a champagne leg or a fluid buildup. So this person is going to end up with knee problems as well. And the single, the picture on the right-hand side of the lady was given a sticky note to go and get compression stockings. So she turned up at the pharmacy to get her stockings, was served by somebody that didn't understand compression. She's motivated by money because she's an older lady with a pension and doesn't have a lot of money to buy full compression and can't don them. So she ends up buying below knee compression, and you can see the results of that there. But it's not just staff. Patients are resistant as well. They have non-compliance. They have an inability to self-manage. They find that garments are too expensive and too hot. They cannot get them on or off. And then they're not explained the risk factors and benefits of wearing staff because staff are, of wearing compression, because staff are actually unable to explain that to them. And then the delays in healing impact the patient's quality of life significantly. And there's a little list there of some of the things we've all heard our patients complain, if we haven't complained ourselves, of problems with delays in healing. And a lot of it is social isolation. I've had patients come in that have had the bottoms of their pants just dripping with lymphorrhea because they haven't been managed properly. So they have social isolation, lots of issues there. So these risk factors for venous disease become evident during your health history. So as you start to tick the boxes, you need to consider vascular disease as one of your differential diagnoses, or as the cause or a contributor. And then we've got some modifiable ones that the patient can actually reduce these risks themselves just by making some changes to their lifestyle. Some other common presentations, so your client may even complain of, or you may see some of these common presentations which are indicative of venous disease. So previously you may have dismissed or thought this information was not that important for a patient with lower limb edema or wounds, but in actual fact, this information is important if you want to treat your patient, because these sort of things rule into having venous disease. You may even see patients presenting with these kinds of conditions. So we've got varicose veins, hyperpigmentation with severe lipodermatosclerosis with leg edema, and then the medial malleoli with venous ulcers. So I wouldn't put an ABPI on the top the varicose veins without a GP consent. I would do B and C. I'd put those people in and take an ABPI of those to see how severe their peripheral artery and venous disease was. After consultation with the patient, working out their pain levels and making sure that I was very succinct in applying that ABPI machine to make sure that I only had to do it once. There are many conditions that cause lower extremity edema, and quite often I'm a lymphedema therapist at heart. So basically, if someone comes in like, I see swelling and I can't just say, oh, this person has lymphedema, I need to be able to rule out these other conditions that also cause edema, and they need to be at the forefront of everyone's mind as well. On further questioning regarding pain and edema, the patient may tell you that the aching stops on elevation and when they rest, but that would actually sound reasonable for a person carrying around a heavy limb or having a nasty wound. Like, you would expect that they would want to rest up and become inactive. However, in the back of your mind, you need to remember that this is also associated with the relief of venous disease. So elevating their legs and taking a rest will ease their pain in their legs, which could be caused by venous disease. The treatment goal is to reduce discomfort, pain and edema and stabilise that skin appearance and remove the painful veins, healing ulcer. So some of these things the patient can do, some we can do as a allied health professional or a registered nurse, and other things a GP or a specialist would need to do, but we need to work together. Class 1 compression can be applied in the absence of red flags without any form of arterial assessment. And we know this because a patient can go into any pharmacy and purchase Class 1, and in fact, they can purchase Class 2 compression garments online. But we need to take an ABPI, which is recommended before commencing compression therapy, which is greater than 20 millimeters of mercury. And the role of that ABPI assessment is to screen patients to rule out peripheral artery disease. So compression selection should be based on the clinical assessment, the patient expectations, and the aim of that compression therapy in combination with the ABPI. So is that compression therapy because it's venous leg ulcers and they've got a wound that we need to help with that blood flow, or is it that they've got lymphedema, or they're maybe post-surgery for some maybe vascular disease? So peripheral artery disease is the narrowing or the blockage of the vessels that carry blood from the heart to the legs. Oops, I just jumped ahead one there. Let's go here. So did you know that if PAD or peripheral artery disease is left untreated, it can result in amputation of a foot or a leg? So this is untreated peripheral artery disease. If amputation occurs, then the life expectancy for 60% of those amputees is just 2 to 5 years. Like, that's pretty bad. So the Australian Institute for Health and Welfare in 2023 report that to date the number of Australians with PAD is unknown. However, it's expected to be 10 to 15% of the population. What they don't know is that over 50% of the people with peripheral artery disease show no symptoms. Therefore, this underdiagnosis leads to undertreatment. Two main causes of PAD: atherosclerosis, which is a buildup of that fatty plaque in the lumen of the arteries, and then arteriosclerosis, which is that hardening or calcification. So these two terms are often used interchangeably or as synonyms for each other. However, they are a little bit different. Risk factors for PAD, a lot of these are modifiable. So tobacco smoking, diabetes, hypertension, being overweight, having a family history, dyslipidemia, and age over 50. So probably a large percentage of us on this webinar today are over 50. And if you look at 50% of the population don't even know they've got that, that's 1 in 2 of us potentially have peripheral artery disease. This is just a quick list of some of the differential diagnoses for PAD, but due to time of this short session today, I'm not going to go through each of them, but you can have a look up what each of these ones here are. And then some other common presentations. So in contrast to the last slide, most of you would have seen or heard your client describe these, and you may have even just brushed it aside as information that, like, you don't really realise the importance, how this is going to inform your treatment. Particularly, we're talking about needing compression therapy with the lower limbs. So an alleviating factor for PAD is dangling the legs down in a dependent position, which helps stop the pain. Now, my dad was a chain smoker, and he used to, you'd always see him sitting on the bed with his elbows on his knees, having a cigarette. And so when he told me that he'd be out walking the floors all night, I just put that down to him needing a cigarette or being elderly and having prostate problems. But in actual fact, inadvertently, he was relieving the pain in his legs. So treatment of PAD ranges from medical interventions such as antiplatelets and surgery to lifestyle changes such as simple things like stop smoking, increase your exercise, lower your cholesterol, so they're modifiable risk factors. In the next couple of slides, we're going to put together the vascular section of our health history with all the information gathering that you're building a list of differential diagnoses in order to find your working diagnosis. So I realise most of us cannot diagnose per se, but we need to have some sort of working diagnosis to be able to inform our treatment plan or to be able to liaise with a health professional. There's no point taking a history to a doctor if you actually haven't taken a history. So of course, sometimes we are nowhere, and that's when we use our referral process. But before we can refer, we need to communicate some baseline information. So a lot of this, you probably may not even be realizing the importance of some of these risk factors in the vascular history. But if your patient is seeing you for a lower limb condition, they've got a wound or they need some bandaging or a compression garment, then you probably need to know the answer to these questions. The more ticks, the more reason to do an ABPI. And I might add here that some GPs and other health professionals will not even consider an ABPI if the pedal pulses are palpable, regardless of the international standards. So as a registered nurse and a lymphedema therapist, I take a full health history at the first appointment and update it with any changes at each appointment because these things do change. And it might sound like it takes a long time to go through all of these questions, but I do an online health summary form that I encourage clients to do prior to seeing me. And the incentive is that if they do the paperwork ahead of time, if they've got more hands-on time. And it's surprising how much of this information is not updated at your GP practice. So next time you're at the doctor's, ask them for a printout of your health history and see how up-to-date it is. You'll be surprised to see there's medications on there you haven't had for 10 or 15 years. And so GP practices have the ability to charge for all sorts of health assessments, which makes them comprehensive. It's also an opportunity to update the file. So a GP's practice doing a health assessment, an ABPI could be something that is done because most of the clients will tick the boxes for needing an ABPI. You also need to take some other general history. You're already always doing this. Medications you need to think about are your diuretics, so anything that has a CCB or like a calcium channel blocker or ends in pine. So the diuretics just continue to add to the oedema. That is another whole topic. People are on diuretics for life-preserving reasons as well as oedema. It's not that suitable for oedema, but like I said, that's a completely new topic. So next we would do our visual and observation, including the pulses. So this is one of the subjects that I teach when I'm teaching my decongestive lymphatic therapy. We have a whole system on how to do a vascular assessment, and I encourage all of my students when they're doing seeing a patient for the first time that they do a vascular assessment regardless of whether they're seeing them for upper limb or lower limb. I'm not going to go through each of these now. They're all really quick, but basically it's a visual assessment and palpatory assessment of below knee of a patient, and we're looking at things like their pitting oedema, temperature of the leg, using the back of our hand. And these tests are really quick and easy to do, and you can do a lot of them just visually. But the ankle brachial pressure index, why would we do this? So it's a quick non-invasive test. It assesses vascular condition to exclude or confirm the presence of PAD. It's not a diagnostic tool, but it does assist the clinician in the safe application of compression therapy, which is recommended for venous leg ulcers and lymphedema. PAD occurs when blood flows to the limb is reduced because of narrowed arteries. It can cause leg pain when walking and increases the risk of heart attack and stroke. So the ankle brachial pressure index, the test compares the blood pressure measured at the ankle with the blood pressure measured at your arm. And to get some idea on how to interpret the results, if you think about this as a percentage and relate it to an exam you've just had. So if you had, if the ABPI is 0.8, that's 80%, and 80% on an exam is okay. But if it said 0.57, that's 57%, you would probably want to be doing a little bit more work. Like that's obviously not a good result. International consensus is lacking for the universal measurement guidelines for ABPI parameters, and this is one that I've taken out of a textbook and just color-coded it. Like for these, you're going to be monitored by what your facility says. So your facility or wherever you're working will have an established guideline. If they don't, you need to look into getting an established guideline so that you've got something to work with. And if you're a sole practitioner and you have an ABPI machine, the ABPI, the book that comes with it will have you the parameters that they like you to use. So according to Wounds UK 2019, all patients with a lower limb wound, but particularly a leg ulcer, should undergo an ABPI test, as should patients who are considered to be at high risk, for example, due to diabetes or immobility, or someone presenting with a lower limb related change. The primary aim of an ABPI test is to assess the health of the arteries at the ankle and determine whether it's safe to apply compression therapy. So just as a side note, a leg ulcer can be defined as a break on the skin which fails to heal within just 2 weeks. And that was by NICE 2016. Best practice statement, Wounds UK 2019. They have a lot of best practices, and I've picked 3 out. So the first one is that an ABPI should be used to identify the presence or the absence of arterial disease in a leg by comparing the systolic pressures in the arm to the leg. Number 2 was it must be recorded as part of an holistic assessment of all patients deemed to require compression therapy, so those with lymphedema or venous leg ulcers. Number 3 was following an assessment of the clinical signs and symptoms and taking a full medical history, the ABPI results should be used to formulate an appropriate treatment plan. So for some of us, that would be a referral. For others of us, that would be actually implementing a treatment plan, as in moving forward with compression therapy or bandaging. The patient expectation as reported in this Wounds UK best practice was if you have a wound or you are at risk of a lower leg wound, you should expect to receive an ABPI test within 4 weeks or sooner. So even if your practice doesn't have an ABPI machine, we can refer back to a GP for a referral to a radiologist or a podiatrist. But having one of these machines in your practice is going to be quite useful. Contraindications, a lot of these are just common sense. Like I always think whenever I'm using any sort of equipment, I always think, is it my mom or my daughter or something? So like, would I want to put an ABPI cuffs on somebody if they were experiencing excruciating pain in their lower legs or feet? No, these people can be referred to radiology and have duplex ultrasounds, which are a little bit less painful. If someone has a DVT, which could lead to dislodgement of the thrombosis, or anyone with severe pain in their lower extremities with a wound or recent surgery, obviously you're not going to be able to put an ABPI cuff on someone with a cast or with already compressed with bandages, someone with an suspected DVT, and it can be less reliable in patients with diabetes or those with known calcification because those arteries are already compressed. In that case, we do a TBI. Also severe oedema and swelling of the limb. What can affect the ABPI values? So diabetes, the arterial calcification can artificially elevate the ABPI. Someone with renal failure, they can have a fluctuating BP, which can elevate the ABPI. Peripheral edema, if we can't apply the cuff because of the size of their limb or if they've got pain. Someone with respiratory distress may not be able to lay flat for a prolonged period of time to be able to perform this test. And there's other things such as a smoker. So you can be a smoker, you just need to have 2 hours without a cigarette to be able to perform the test, or it's recommended. And then there's other external factors such as a cold room. So we need a warm room, which encourages dilated blood vessels, which makes those arteries easier to find. If the patient's anxious, they'll have an increased blood pressure. If the clinician's anxious or doesn't know how to perform the procedure correctly, those things can also affect the ABPI values. And of course, repeated inflation of the cuff, which is going to cause venous congestion. The advantages of a SmartDop XT4 or 6 automatic ABPI, it reduces the clinician's time. So if you are a doctor, you can have any other members of your staff doing this, but they can't always interpret it for you. So anyone can do the test, but you need to be qualified to do the interpretation. So it's a bilateral measurement, which is done in just a few minutes. You can apply the 4 cuffs, so it reads the arms and then the ankles and then the toes if you're going to put the toes on. It records the highest ankle pressure in all 3 arteries. So that's your anterior tibial artery, your posterior tibial artery, and your perineal artery. The patient doesn't need to rest. However, my practice is on a hill, and so I do get my patients to have a little bit of a rest after they've walked up the hill because they have definitely got an increased blood pressure after doing that. No need to take off the socks. It's clinically validated and it improves assessment levels with better patient outcomes, and it facilitates early detection of PAD. And I've got a couple of case studies coming up that I'm going to show you that. When would a TBI or a toe brachial index be performed? So for some patients, an ABPI can be unreliable. So that's our diabetics and our chronic kidney disease and the elderly. So in that case, the toe vessels are less susceptible to calcification and incompressibility than the ankle arteries. So we would do a TBI. Who can perform an ABPI? So all users and clinical staff, including registered and non-registered staff, should be trained though in using the relevant device and in the general principles and importance of an ABPI. And of course, you need to do your due diligence and work within the scope of practice of the actual practice. So some GPs like to do everything themselves, others will have their nurses or ENs do this. The interpretation needs to be done by a qualified health professional, such as a radiologist, a doctor specialist, or a podiatrist. A lot of podiatrists are doing ABPIs because that's their that's the area they work on in the body. So just regarding the billing for this, it has a Medicare item number of 11610. So this is for most ABPI machines. So what that means is the fee is $69.75, and I've got the two benefits there, the 75 and the 85%. It takes less than 5 minutes per patient to do this test. So therefore, it's not only a great clinical addition based on international consensus, but it's also really good commercial value add-on for practices. So we'll talk a little bit more about that in a moment. So recouping your costs. So any person presenting, these are the people that you would see. So the people that you'd want to test according to the international consensus. So these people should have an ABPI. Anyone that presents with a lower leg wound or an ulcer, which we know is 70% of the wounds that come through GP's practice. Any person requiring medical grade compression. So this person could be a lymphedema patient, someone going on a lot of travel that suffers with a lot of edema in their ankles, pregnancy, immobility. We often see this in nursing homes where they are in wheelchairs for extended periods of time and they end up developing dependency, edema. They get put into compression stockings below knee, but they probably should have an ABPI first just to check that. Anyone post-surgical, and there's a whole heap more. Diabetics can have 2 per year. Anyone over 65 and anyone over 50 with cardiovascular risk factors. So a lot of GP practices have health assessments for the over 75s, and this probably should be just a part of that. So if you're considering purchasing an ABPI machine, then if you do a quick sum of the purchase price divided by the Medicare rebate, you'll find that even with bells and whistles and staff, you're probably only going to need to see 100 patients to be able to recoup that. Now that sounds like a lot, but a lot of people here are in multidisciplinary practices. And even if you're allied health and you're working in an allied health system or centre where you have a lymphedema therapist and a podiatrist and maybe a physio and an OT, there's a lot of people in that practice that would be able to use the ABPI machine. So it's easy to substantiate why such a piece of equipment is a necessity and a viable addition to your practice. Like think of the difference an ABPI would have made to my dad's diagnosis or lack of diagnosis. It would have informed treatment for him, which would have reduced the burden of cost on the health system as well as his own pocket. It would have freed up clinicians' time and it would have given him so much more improved quality of life. And mums, like they lived on a farm with tank water, so washing sheets all the time was just a nightmare. There's been lots and lots of studies. I've just grabbed this one from Kane et al. In 2022. The aim of this study was to critically review and analyse findings from contemporary literature with the aim of evaluating the effectiveness of the ABPI screening tool. And their method was a structured literature review using a narrative approach. And then they did 4 studies were identified for inclusion, and they involved medical, nursing and allied health professionals in primary and secondary care with 51 patients in total, and 8 themes were identified. The conclusion here was that it's important to undertake a holistic assessment of the patient, incorporating an ABPI assessment unless it's contraindicated. The key points were that an ABPI is an effective assessment screening tool for early identification of PAD or peripheral artery disease and for assessing suitability for lower limb compression therapy, although they did state that it should not be used in isolation but as part of a holistic patient assessment, and I've been saying that already today. Performing an ABPI is really quite simple. You just explain the procedure and obtain consent. The patient lies supine with arms by their side in a relaxed and comfortable position. We ask them not to talk during the consultation or the test unless they have to, if they've got pain or something. If there's wounds present, you can protect those with cling film. So the wound would be dressed and then you put cling wrap around that so that it protects your cuffs. Put a cuff on each system. There's a diagram there with showing you the placement of the leads for the cuffs. Check everything's okay and press go. So I've got a couple of case studies that I just wanted to show you. If you look at this person's legs, and I'm showing you this particular lady's legs because I don't want you to become complacent about doing a visual assessment and thinking, oh no, those legs are okay. So I didn't see these legs as a problem, but this lady needed lower limb compression and I thought, I've got an ABPI machine, let's just do it. So international consensus does say, which this is what confirmed that I needed to do this is because the international consensus says that a patient requiring lower limb compression should have an ABPI. So that was my tick to be able to do this. Had I not done a health history, palpation, examination, and an ABPI, I would have unknowingly put this lady in class 2 compression and sent her on her way. So she's 55, she has a past history of smoking, socially, hyperlipidemia, gestational diabetic 30 years ago, BMI of 27, she has lipedema, but no significant family history of cardiac disease. And when you just look at those legs, they look like they need to see the sun. You can't actually see, like if you look in the medial malleoli, there's no real vascular problems, there's no ropey veins. I would have just said, yep, let's put you in class 2. Her right ABPI came back at 0.72 and her left at 0.83. So she has mild peripheral artery disease in her left and getting onto the lower range for her right. And her toe brachial indexes are both abnormal with mild to moderate peripheral artery disease. So I just wanted to show you those because even though that looks okay, she's only got mild peripheral artery disease, but this actually warrants further investigation. And I put her in compression, but I need to check in with her more often at the beginning so that to make sure she's not having any untoward symptoms. And this also warrants further investigation with a referral back to her GP with a copy of the results, a succinct history, my findings, and asking if that GP will follow this up with a vascular appointment, because at 55 she's got time to redeem herself and not end up with an arterial ulcer, which then could lead to amputation, and then the 60% of those people at death of after 2 years. So this is why it's important in my mind to do an ABPI. This second client of mine is a 74-year-old male. He's a retired fireman. He has increasing, or he came to see me because he had increasing lower limb edema over 18 months. No significant family history, although he did have risk factors of a coronary artery bypass graft, aortic valve replacement, atrial fibrillation, hypertension. He came to see me because he needed new compression. I looked at these legs and I thought it probably does warrant an ABPI. So he has cardiac risk factors. This is what prompted my ABPI. He has hemosiderin staining, which is that colour you can see in his legs there. He has scant lower leg hair growth, no hair on his toes, really poor toenail health. He had vascular changes. He had temperature changes in his leg. So we did an ABPI on him. He also needed a medication review because he was on 4 different diuretics to help with his apparent edema, but he also needed some for life preserving. So we did an ABPI on him. The GP sent him off. This was his results. So his right was 1.29 and his left was 0.76. So we sent him off to, I sent him back to his GP, who sent him on to a vascular surgeon. I would have put this guy in class 2. He was already in class 2, but his specialist has said he only requires class 1 compression stockings and he needs to look at his medications because he's on the amlodipine, which can increase edema. He needs a change to Lasix. So had I not done the assessments on this guy, I would have put him back in class 2, and really he only can have class 1. So just a quick diagram. Whichever ABPI, if you're ever going to have one or you've got one in your practice now, it'll have a book. This is just a picture of the XT Smart Dot. So it has blue on one side and for your right limb, and the other side is clear. If you look up here on the machine, the other one is clear, which goes on your left limb. It comes with a program, which is very easy. Just press start at the bottom and it's all automated and very self-explanatory and works for you. It comes with diagrams on how to place the cuffs. The only thing that I disagree on is I place the brachial cuffs on like we do a regular BP. and the ankle ones go in the medial malleoli side. And then this is the parameters